All right, let's quick do a quick review. Airway anatomy. Upper airway consists of what? From the larynx up, right? The big tube and all those little structures that kind of get in the way, that kind of just hang there and dangle there and swell up and all that kind of stuff, right? Why is it important for us to have a good idea when we're doing advanced airway techniques to know our anatomy? Because we got to know what to look for, right? We've got specific identifying markers that are going to be important whenever we go to intubate. We're going to need to look for that vallecula. We're going to need to look for that epiglottis. All right, we're going to need to identify the epiglottis if it's swollen up. We're going to need to identify the tonsils if they're swollen up. Lower airway, what's that consist of? From the larynx down, right? Including the trachea, the bronchioles, the terminal bronchioles, the alveoli, right? What is the main purpose of the lower airway? For gas exchange, right? To take in the oxygen that we're breathing in and to do what with it? To give it to the blood, right? To be the trash truck to pick up the waste, and to be the delivery, to be the UPS, and to deliver the oxygen, right? All right. External respiration occurs where? Not just in the lungs, at the alveoli capillary level, right? Internal respiration occurs where? At the capillary cellular level, and then cellular respiration will actually occur inside the cells, where the cells will utilize oxygen to metabolize, go through aerobic metabolism. When we breathe under the principle of what type of pressure? We bring in a breath under what type of pressure? Negative pressure. Negative pressure. What causes that negative pressure? Contraction of the diaphragm and the intercostal muscles. What is that reflex called that tells our lungs, hey, you've stretched out, it's time to release? The Herring-Brewer reflex. A lot of your breathing, the control of your breathing is actually stimulated and controlled from which body system? From what? The nervous system, right? The central nervous system. More or less the autonomic nervous system, right? Now, the actual process of breathing has somatic properties and autonomic properties, right? Because you can actually tell yourself to take a deep breath, you can tell yourself to hold your breath. But if you're not thinking about breathing, you don't have to think about breathing, right? The guy on the interactive lecture is talking about imagining having to tell yourself to breathe 12 to 20 times a minute, every minute, for 60 minutes, for 24 hours. I would get tired and probably just be lazy and die. What is the most common airway obstruction? Your tongue. Celia, what does it do? Filters. It filters. The palate separates what? The nose from the mouth, right? The nose hole from the mouth hole. You got a soft palate and a hard palate. What could be a consequence of intubating somebody with the blade and all that to the palate? We could cause trauma to it, right? One of the things that we know about the airway is the fact that it is very sensitive. It can be traumatized very easy. When we're doing advanced airway management, what is important about this? Okay, so this is what? The thyroid, and this is what? Cricoid, the first ring below the thyroid. So if we're going to actually do like a needle cricothyrotomy, we're going to need to be able to locate this area right here But if we're doing airway, and we notice, hey, maybe the esophagus is opened up or something like that, or the airway is more anterior, we can apply what type of pressure? Cricoid pressure, right. We're going to be looking for the pearly whites whenever we go to intubate. That's going to be important. The first time you actually intubate somebody and you see, in a real live person, you see their vocal cords, it will look a lot like this, all right? It may be vomit, full of vomit and blood and all that, but if you can actually locate the vocal cords, you will see at least a lighter color there at the vocal cords. Talked about all this. I don't think that we really need to hit all that. Boyle's law. Somebody remember these laws? Remember these partial pressure of gases and all that? What does Boyle's law say? Okay, the pressure of gas is inversely proportional to its volume. Basically, the more oxygen, the more partial pressure of oxygen that you have in the air, the more it is available to be diffused into the blood, right? Gases act off the principle of diffusion. Fluids act off the principles of osmosis, right? Gases act off the principles of diffusion. Remember all these laws, Henry's law, Boyle's law, the Herring-Brewer reflex, those are going to be important. Just really in the most simplest terms that you can tell me, what is the partial pressure of a gas? Okay, so the amount of available gas that would be in the atmospheric pressure that can be dissolved in the liquid. Okay? What is the partial pressure of oxygen in the air that you're breathing right now? 21%. So that means that you've got 21% available oxygen to be dissolved in the blood. Now you do lose some along the way. How would we increase the partial pressure of oxygen? Yeah, providing supplemental oxygen, right? So if we breathe 21% on just atmospheric air, if we're placing a non-rebreather mask, which is just straight oxygen, that oxygen is going to take the place of the nitrogen and the trace gases and all that that's in the air, and it's going to be 100%, give or take a little bit, of just straight oxygen, right? Does that make sense? Right now we're breathing 21%. If we give somebody 100% oxygen, it's going to be 100% oxygen. I don't know how to explain it really any deeper than that. Just remember your tidal volume, the amount of air that you're bringing in. Where do we lose volume at when we breathe in? The dead air space. What's the normal tidal volume? 5 to 750, right? Normal dead air space volume is going to be 150. Exhalation is a passive process. And remember, old Herring-Brewer is the one that tells us to release it, right? What actually sends the signal? All right, chemoreceptors. And baroreceptors play a role in it too. Regulation of ventilation. So the chemoreceptors, they pick up on levels of what? CO2. They look at the levels of CO2 and oxygen, right? Mainly CO2. The medulla is your primary respiratory control, and then the pons is where the apneustic center is. It's the secondary control. So, again, the primary respiratory control center is the medulla, right? Y'all should know that back from advanced. The primary chemoreceptors that that look at the pH of the blood are in the carotid bodies, so here, and then in the aortic arch, right? And then the chemoreceptors that are in the central nervous system are the ones that pick up the pH and the amount of CO2 that's in the what? Cerebral spinal fluid. Somebody tell me what the hypoxic drive is. Okay, so the body gets used to having higher levels of CO2 in the blood. So a normal person, and I think I might have actually said this backwards last week, but a normal person, the stimulus to breathe is going to be, hey, we've got increasing levels of CO2, so we need to breathe to get some of that CO2 off, right? In a healthy person. But in a person that has a chronic lung disease, they're going to be used to retaining CO2, right? So their body's not going to be triggered to breathe off of higher levels of CO2. So what is their body going to be triggered to breathe off of? Low levels of O2. So that's why giving them a lot of supplemental oxygen could actually just tell them to quit breathing altogether, because the body's going to say, hey, we've got high levels of oxygen, we don't need to breathe. Does that make sense? Okay, great. Talked about this. The FiO2 is a percentage of oxygen inhaled air. So really and truly, the 21%, when we look at it as FiO2, that's the fraction of oxygen that's in the air, okay? And then the partial pressure is going to take that 21% and push it into the liquid, okay? If you've done clinicals in respiratory, remember I talked about it last week, you can look at the ventilator and actually look at the FiO2 that somebody's breathing in. So we're actually determining how much inspired oxygen they're going to be receiving. Hemoglobin, what does it do? It carries oxygen. It's a protein bound to what? Red blood cells. And then the hematocrit is going to give us the percentage of red blood cells in whole blood. So if we've got a low hematocrit, we're probably going to have a low what? Hemoglobin. All right? This oxyhemoglobin dissociation curve, just go back and read into that. I don't want to spend all day looking at all this again. The biggest thing that we need to remember, and we're going to get an acid-base balance in just a minute, acidosis, all right, acidosis is going to actually, is not necessarily going to interfere. Let's see if I can think of this right. Acidosis is going to keep the blood from entering into the cell. All right, so if somebody, not the blood, the oxygen, if somebody's in acidosis, the cell's going to have a hard time uptaking oxygen, okay? Somebody that's in alkalosis, and in acidosis, the oxygen actually does have a harder time binding to the hemoglobin too, okay? So acidosis, the oxygen has a hard time binding to the hemoglobin, so the cell's not going to get oxygenated. In alkalosis, it more or less, it doesn't really affect the amount of oxygen that's bound to the hemoglobin. It more or less affects the fact that the hemoglobin won't release the oxygen as easy. So if somebody's in an alkalotic state, the hemoglobin won't release the oxygen as easy. All right. I think we can briefly go through this. External respiration, I've already asked you that. I don't think we need to hit this again. We know that aerobic metabolism is metabolism in the presence of what? Oxygen. What is the byproduct of aerobic and anaerobic metabolism? What? Okay. The byproduct, one of the waste products of aerobic and anaerobic metabolism is going to be pyruvic acid. All right, but the difference in anaerobic metabolism and aerobic metabolism is that in the presence of anaerobic metabolism, that pyruvic acid is going to be converted into lactic acid. And that's when we're going to go into lactic acidosis. Okay? This is all part of the Krebs cycle. Again, I'm not a biology instructor, and so we're not going to get into the whole Krebs cycle and all that kind of stuff. That's stuff you should have got in 103, Biology 103. But just know that energy is produced in the form of ATP. And which one is going to produce more energy, aerobic or anaerobic? Aerobic. Anaerobic is kind of the body's the compensatory mechanism in the presence of a deoxygenated environment. Problem with anaerobic metabolism, the cells will die. So really, carbon dioxide is a byproduct of the mitochondria. If we're going to get deep into it, carbon dioxide, we know that it's going to be, all this is going to be the byproducts of the metabolism. But the mitochondria uses the oxygen to convert the glucose. Those of you that's had me in advance, what are the two things that the cells need? Oxygen and glucose. Oxygen and glucose, right? Oxygen and glucose. So, under normal circumstances, the oxygen is going to convert the glucose to energy, carbon dioxide accumulates in the cells, and then the carbon dioxide then further converts into carbonic acid, which is then transported through the blood, right? But then, without oxygen, the anaerobic metabolism leads to cell death because of the byproducts that it accumulates. Ventilation is what? The mechanical process, right? It's moving air in and out. So when we're doing vital signs, we say we're counting respirations, but in reality we're actually counting ventilations. And so oxygenation is going to be the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. So actually, when we talk about internal and external respiration, the actual process of getting the blood at the external level, getting the blood saturated with oxygen, is actually oxygenation. Does that make sense? And then respiration is going to be the exchange of carbon dioxide and alveoli in the tissues of the body. We know what happens if you have a disruption in pulmonary ventilation, right? You become hypoxic, right? You become acidotic. We know what perfusion is. This is just an interesting little chart. 0 to 1 minutes, you start getting cardiac irritability. Another term for cardiac irritability is what? Excitability. 0 to 4 minutes, that's kind of the window, all right? We need to get oxygen on them. And then 4 to 6 minutes, that's where brain damage may begin. Then 6 to 10 minutes, we're looking at brain damage is very likely. Then after 10 minutes, I mean, really and truly, between that 6 and 10 minute window, we don't want them that long without oxygen. Because they're going to probably have some brain damage that can't be fixed in 6 to 10 minutes, all right? What is it called whenever you have a brain injury due to lack of oxygen? It's called a blank brain injury. Starts with an A. Rhymes with anoxic. Anoxic brain injury. So, really, without spending a lot of time on this, because I don't think we need to, if the cells don't get oxygen, they become what? They go, when they become hypoxic, they start undergoing what type of metabolism? The byproducts of anaerobic metabolism lead to what in the body? Acidosis. All right, you're not wrong, but I was looking for acidosis. The early signs, restlessness, irritability, then the late signs, severe mental changes, and all that. Somebody explain to me what the VQ mismatch is. what a VQ mismatch is?
A failure to match ventilation distributions or VQ mismatch lack between those abnormalities and oxygen carbon dioxide.
Thanks. Now, in your own words, what is it?
The amount of air coming in doesn't match the amount of blood within alveolar, the capillary blood cell level.
Okay, all right. So really, even more simplified than that, you're either going to have a problem with ventilation or you're going to have a problem with respiration, right? It takes two processes for good breathing to occur, right? Ventilation and respiration, right? So a VQ mismatch could be something as simple as a foreign body airway obstruction. I don't have a problem with my lungs. If I could actually get oxygen to my lungs, they would be able to utilize that oxygen, right? The mismatch is the fact that I'm having problems with ventilations, right? Another example could be like a pulmonary embolus. I don't have any problems getting oxygen down to my lungs. The problem is that my lungs cannot utilize that oxygen because I've got an emboli. Make sense? So ventilation and perfusion must be matched. You need to have an open tube and you need to have a good oxygen factory, right? And obviously, you don't need anything to clog that up. So a patent airway is going to be very important, right? Why are we even going into this as paramedics? Well, it's very important to remember your basics, okay? Because you may go to the scene of an unresponsive person and it may be something as simple as just getting that chunk of catfish out of their throat, right? I mean, really. It doesn't really have to do with oxygenation, but my wife used to be a pediatric nurse, but now she works in endoscopy at East Alabama. And she was telling me about, and I hope that y'all don't know this guy. I've got a friend that has a friend that works in an endoscopy lab somewhere far away from here, that a guy came in and he had steak stuck in his esophagus for like 5 days, and it started rotting. Yeah, he had some bad breath. I don't know where that came from. As far as affecting the mechanical process of ventilation, you've got your intrinsic and extrinsic factors. The intrinsic factors are going to be causes from the inside. Anything that's going to cause what? Obstruction. And usually if we have an intrinsic factor that's causing an obstruction, the obstruction is either the tongue or what? What? No, from the inside. Laryngeal edema, swelling, right? Can be caused by anaphylaxis, some type of infection, or unresponsiveness. So intrinsic, really the only physical thing that's going to block the airway is going to be that tongue. All right? The other things is going to be swelling and including of the airway. Extrinsic, obviously foreign body airway obstructions or trauma. If you get your teeth knocked out or you're vomiting or you're just profusely bleeding. But that goes a little bit deeper. Trauma goes a little bit deeper than just airway obstruction, because how can trauma that isn't an obstruction to the airway, how can another type of trauma affect your breathing? Yeah, anything that compromises the integrity of the chest wall, right? Because the chest has to be able to pull that negative suction. So if we have a flail segment or a tension pneumothorax or, a sucking chest wound or something like that, that can lead to inadequate pulmonary ventilation, right? Because we're not going to be able to bring that oxygen in. When we hypoventilate, what builds up? CO2, right? Why? Yeah, you can't blow it all. When we hyperventilate, what happens? We blow too much CO2 off and the body becomes acidotic or alkalotic? Alkalotic. in high altitudes, heard of altitude sickness, the partial pressure decreases, so that means that we have less available oxygen to do what? To dissolve in the fluid, right? Also, closed environments, confined spaces. Firefighters do confined space rescue. Not only is it an oxygen depleted environment, but eventually, in certain confined spaces, toxic gases can start building up. What helps increase the surface area for gas exchange? What helps expand the alveoli? Surfactant. So you can have some conditions that reduce the surface area. So if it's going to reduce the surface area, what do you think it's going to affect? So the surfactant increases the surface area of what? The alveoli. What does increasing the surface area mean? It means increasing the amount of space that it's going to occupy, right? When I blow a balloon up, I'm increasing the surface area, right? So the surfactant helps aid in increasing that. It lubes it up, right? So you may have some disorders that's going to inhibit the availability of the alveoli to expand, okay? What are those? Okay, emphysema, some type of chronic lung. What about pulmonary edema, right? Because it's going to take up that space. It's going to take up the space in between the alveoli and the capillaries, not going to allow it to expand. All right. What? Histamine? Well, histamine is going to affect it, and it is going to decrease the surface area or the available surface area, because what does histamine do to the lungs? What does an anaphylactic reaction do? It bronchoconstricts, it locks it down, right? So when it's locked down, it can't expand. So yeah, you're right. Also, drowning victims or exposure to other environmental conditions such as toxic gases, asbestos, I guess, things like that. Then other things that affect oxygenation and respiration, hypoglycemia. So we may have oxygen, but if we don't have glucose, we're not going to properly do what? Metabolize, right? And we know that that certain blood sugar disorders could lead to acidosis in the body, right? And we know that acidosis in general affects cellular perfusion. Infections and also hormonal imbalances. Obstruction to blood flow is typically related to trauma. Anytime that you're going to have an obstruction of blood flow, anytime you're going to have blood not being able to come back to the lungs, is obviously going to do what? Inhibit gas exchange, right? Because there's nothing there to exchange the gas. Just kind of what we briefly talked about yesterday, what heart conditions would reduce blood flow? Anything that's going to inhibit cardiac output, right? Whether it's cardiac tamponade, heart failure, cardiogenic shock, anything that's going to affect the available preload, which in turn is going to affect the available cardiac output. Shock, I think that we know shock pretty well, right? Shock is what? Inadequate perfusion. Okay. The acid-base balance. I have a love-hate relationship with the acid-base balance. I love the concept of it. I hate actually trying to explain it and trying to get it out of the way I understand it to you guys, okay? Obviously, acid-base balance is hypoventilation, hyperventilation, hypoxia, all are going to affect the acid or the alkali environment. The respiratory and the renal systems help to maintain homeostasis. Somebody tell me one way that the respiratory system affects acid-base balance. Yeah, blowing off CO2, right? What's one way the renal system maintains acid-base balance? What? Okay, how does it affect the pH level? It secretes what? Sodium bicarb. Sodium bicarb. Remember, sodium bicarb is the what? Buffer. The fastest way to eliminate acid is going to be through the respiratory system because we can blow it off, right? We can blow it off. Obviously, increasing respirations is going to do what to the pH? If we increase respirations, it's going to do what to our pH? It's going to increase it, right? You following me? Hillary's in the building. All right. Let's just review this real quick. Acid base, pH, is measured on a scale called a what? Inverse logarithm. All right? So normally 7.0 is neutral, right? But in the human body, for us, if we're looking at, so we're going to say 7.0 neutral. But for the human body, pH is what? 735 to 745, right? So, anything, that's a big gap, but anything that is to the left is going to be what? And then anything to the right is going to be what? We're looking at the patient's right and left, right?
Trying to save yourself.
So it's just always stuck to this one thing. You're so patient care.
So, anything to the left of 735 is going to be what? Acid, right? So, if we're increasing respirations, hyperventilations, right? Hyperventilations, we're going to actually decrease the CO2, right? So it's actually going to increase the pH, right? Does that make sense? And so if we hypoventilate, we're going to do what? Increase the CO2, but it's going to decrease the pH. All right? The renal system regulates the pH by filtering out more hydrogen and retaining bicarbonate when needed, or doing the reverse. So just like the respiratory system, it maintains pH by either increasing or slowing breathing. The renal system is going to either get rid of hydrogen, and when we get rid of hydrogen, we're going to actually be getting rid of what? Acid or base? Acid, because an acid is anything that can donate a hydrogen ion, right? Which means it's got an abundance of hydrogen ions. So the renal system is either going to decrease the amount of hydrogen and maintain the amount of bicarbonate, or it's going to increase the amount of hydrogen and decrease the amount of bicarbonate. Okay? And again, this is something that if you're not quite grasping, you're just going to have to read over it and look over it. Alkalosis can develop if respiratory rate is too high. Can lead to respiratory acidosis or metabolic acidosis alkalosis. Alright. They did not spend the amount of time that I wanted to on pH. I want us to look at something real quick if I can figure out. This is going to be just a quick look at how we are going to be able to determine, by looking at blood gases, arterial blood gases, quick look at how we're going to be able to determine if it's metabolic or respiratory, okay? Now again, this is only a very superficial look at it, and it's what we need to know, because you can actually get into things where you could be in acidosis and it doesn't even affect the pH, or the pH could be affected and the sodium bicarb could be affected, and so it gets really, really confusing with all that. But this is just a very simple way to look at it. And the reason why I'm going to tell you this is because some of you may end up going into some type of critical care medicine. And they actually have machines that you can draw blood gases in the field. They're called ISTAT machines, that you can draw blood gases in the field. So if you go on like if you go to work for like a critical care ICU transport or something like UAB or Emory or something like that, you may be required to know how to look at blood gases. All right? So, what's the chemical letters for bicarb? HCO3? So we know normal pH is what? Normal CO2, what is it? Do y'all know? What's normal bicarb? What does your book say normal bicarb is? Does it even tell you? Okay. So normal bicarb would be 22 to 26. Okay? So the way that we're going to tell if it's acidosis or alkalosis is going to be to look at what? The pH. The way that we're going to be able to determine if it's metabolic or respiratory is going to be to look at what? CO2 is going to be respiratory and bicarb is going to be metabolic, okay? So let's just look at an example. So I've got a pH of 7.30. Alright, so I know that that's what? Acidosis. Alright? I've got a CO2 of 40 and I've got a bicarb of 12. Alright, so I've got a decreased bicarb, I've got a normal CO2, and I've got a decreased bicarb. I meant to say pH up there. Metabolic or respiratory? Metabolic. Now, why would we, how is it that we could have a normal CO2 but still have a decreased pH? Exactly right. Because if there's not enough bicarb, that means there's going to be more hydrogen ion. There's going to be more acid, right? Okay? You following me? Respiratory or metabolic?
Respiratory.
All right. First thing is what? We're what? Alkalotic, right? What is unique about this? It's low. All right. So a decreased CO2 is going to be an increasing pH, right? So what's probably happened? Somebody said it just a minute ago. Somebody hyperventilated, okay? So, one thing to look at when you do let's see. When you actually look at blood gases, is you can look at the arrows. You can actually look at the arrows. If you look at your numbers and put an arrow next to it, and does it show it like that in your book? If you look at your numbers and you look at the arrows next to them, that can kind of help you, okay? All right? So, if I have we're going to look at respiratory acidosis. All right? So in respiratory acidosis, our pH is going to be low or high? Our CO2 is going to be low or high? And our bicarb is going to be normal, right? Respiratory alkalosis. pH is going to be low or high? CO2 going to be low or high? Bicarb? Alright. And now again, let me reiterate, this is just a superficial look at it. If you do go to nursing school or get into some critical care stuff, they will get into compensated, decompensated, and all that. But we're not doing that part. Alright, so metabolic acidosis. pH high or low? CO2, maybe not affected. Bicarb, high or low? And then metabolic alkalosis, pH high or low? CO2 and bicarb, high or low? What do you notice about the arrows in respiratory? They go opposite, right? What do you notice about the arrows in metabolic? They go the same, right? So the first step, if you're interpreting a blood gas, is just going to throw you a little arrow next to it, all right? And see what it tells you, okay?
Rome.
Huh?
Rome.
Rome? Oh.
Respiratory opposite metabolic.
Yep, that's right. That's right. I hadn't heard that one in a long time. Thanks, Mike. Remember this. Rome. Respiratory opposite metabolic equal. And you know what they say, when in Rome. What? When in Rome what? Does that make sense? Anybody? I guess there's people in here that's never heard that. When in Rome. Watch Anchorman. All right. All right. So we're almost done. So to get us on through, let's just go through these last couple of assessment slides. I don't think we need to spend a lot of time on these. We're going to look for respiratory rate of 12 to 20, right? What's one of the keys? One of the key things is going to tell us if they're not getting oxygen to their nodules.
They're not breathing.
Well, if they're not breathing, that's obvious. Altered mental status, right? Anxiety, appearance. If somebody can't breathe, if somebody's in respiratory distress, they're usually not going to do a good job of hiding it, right? Remember this. Respiratory distress, if not treated promptly, will quickly lead to what? Respiratory failure, if not treated promptly, will quickly lead to what?
Respiratory arrest.
Respiratory arrest, if not treated promptly, will quickly lead to what?
Death.
Death. What?
L trip.
Cyanosis, bluing, right? Is going to be an indicator that we're not getting perfusion, right? We'll most often find folks in the tripod position, right? Kind of leaned over, maybe got their head up. What does tripoding do? It helps give them more of an open airway, okay? And it helps actually take some of the stress off the lungs as well. Semi-Fowler position. A person in respiratory distress cannot lay flat, right? They cannot lay flat. Inadequate breathing. I don't think, if you don't know potential causes of inadequate breathing at this point, you may need to go back to EMT school, right? Even though we're medics now, we are going to always do what when it comes to airway management?
Start with the basics.
ABCs. We're going to do our basics first, right? Because if we don't get that airway open, it ain't going to do us a bit of good to spend a whole lot of time trying to intubate somebody if we're not already getting oxygen to them. Part of your assessment is going to be to auscultate. Part of your higher learning is to be able to do a good assessment and to auscultate and be able to determine what's going on in their lungs. Y'all know how to assess. Is there anybody in here that does not know how to assess a respiratory distress patient? All right. What is staccato speech? I always thought staccato was that stuff that went on the outside of a house, right? Yeah, one or two speeches, one or two words. You thought it was what? Yeah, it sounds like it could be. Obviously, if they're having inadequate breathing, they're not going to be able to talk. Slurred speech, slowed speech, all that stuff's going to have a big assessment findings. Assess for pulsus paradoxus. Systolic blood pressure drops more than 10 millimeters of mercury during inhalation. I got that totally wrong yesterday when I was telling y'all that. That's going to be seen in patients with conditions that cause an increase in intrathoracic pressure, such as COPD, decompensated COPD, severe tamponade, tension pneumothorax, or severe asthma. Ask about the history. Your OPQRST, we may not get all of our OPQRST stuff, but at least get a good, thorough history of what's going on. Also look for their medications. Whenever we get ready to start intubating and messing with their airway, we need to be sure that we are aware of their gag reflex, right? Other airway reflexes: coughing, sneezing, gagging. Listen, if you pick somebody up that has a bunch of junk in their lungs and they're coughing, do we want to stop them from coughing? No. No. You hardly will ever see a patient admitted into the hospital that receives frequent cough medicine. All right. Now, if it's something that's just causing them labored breathing and they're not getting anything up, if it's not productive, they may try to suppress that cough a little bit. But coughing is the body's natural way of sucking stuff out of your lungs, right? And we don't want to suppress that. Hiccuping, I don't really know as far as reflexes what good it does other than just gets on my nerves. We're looking for clear, equal, bilateral breath sounds, right? We want to hear the same thing on the right side as we do the left. So when we auscultate, do we go 1, 2, or do we go right, left? Right, left, because we want to compare what we just heard, right? These are just areas for you to auscultate. So remember, when we get into assessments, and even now when we're doing airway management, it's going to be very important for you to get into the habit of listening. So I know that all of you have stethoscopes at this point. Go ahead and get into the habit of having your stethoscope in the bag so that you'll have it on you to get in the habit of listening even when we do the mannequins, okay? Very important. Your stethoscope is going to be one of your most valuable tools that you have in healthcare. Normal breath sounds, a couple new terms that I don't talk about a whole lot is bronchiovesicular and vesicular. Your tracheal, obviously, you want to hear good sound over the trachea. Your bronchioles, you want to hear down deep. Your bronchovesiculars, inspiratory and expiratory sounds are the same and of medium intensity. So bronchovesicular, we're going to be listening over the bronchioles, and we're going to be making sure that a good bronchiovesicular sound is going to be the same in and out. And then vesiculars, inspiratory sounds, last longer than expiratory sounds, and both are faint. So the thickness of the bars indicates the loudness. So if it's real thick, it's supposed to be a little bit louder. Your vesicular sounds, your inspiratory to expiratory ratio. Inspiratory sounds last longer than expiratory sounds. Alright? Your IU ratio is 1 to 2. Expiration is prolonged with lower airway obstruction, or expiration is short with tachypnic patients. Your pitch, what's going to really have a effect on the pitch of your airway sounds? The lumen of the tubes, right? The passage, the airway passage. Is it obstructed or is it tightened down? We have a tightened down lumen, we're going to have a higher whistle sound, right? A higher pitch sound. Depends on, obviously, airflow, patient position, but most often stridor and wheezing is either going to be because we've got an obstruction in the upper airway, and that's decreased the lumen of our trachea, right? Or we've got bronchoconstriction, and that's decreased the lumen of the bronchioles. Wheezing is probably the easiest adventitious breath sound, right? You can hear wheezing. Somebody that's really wheezing, you don't even have to put a stethoscope to them, right? Rhonchi is going to be a continuous low-pitched rumble down in the lower airways. Crackles is going to be discontinuous. Does anybody remember the way that I described rails? Rails are wet like whales. Rails can often be with crackles. And you can have Fine crackles or coarse crackles? Anybody remember the way I described fine and coarse crackles? Bubble wrap. Right. You've got the real small bubble wrap. It goes pop, 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 pop. Or then you've got the big bubble wrap that's slower, and it's pop, 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 pop. And really, somebody that's really got some really wet breath sounds, some real bad crackles, it really will, you will hear like a popping sound, because that's what it is the air's getting down, and it's aerating the fluid that's down there, and it's creating bubbles, and it's popping the bubbles. Strider, upper airway, right? Pleural friction rub. What would cause a pleural friction rub? Yeah, decrease of pleural fluid between the visceral. The visceral is very close to the lungs. The parietal pushes away from the lungs, right? Pulse ox. We want it greater than 95%. Pulse ox measures what? The percentage of oxygen in the blood, but more in detail, the amount of what on what? The amount of oxygen on the hemoglobin. All right? Is pulse ox always going to be our most reliable airway tool? No. Because it's just measuring the amount of saturation on a particular hemoglobin, right? Remember, or the example that I use is that, say it takes 10 hemoglobin molecules to adequately perfuse the body. I'm anemic and I only have 5. But all 5 of those hemoglobin molecules are 100% saturated with oxygen, so they're all full. What's my pulse ox going to show? 100%. But if it takes 10 hemoglobin molecules to perfuse my body, am I going to perfuse my body with just 10 or 5? No. If all 10 of my hemoglobin molecules are 100% saturated, what is it going to show? 100%, right? And then I'll get perfusion. So you'll hear it a lot in cardiac when we get to cardiac monitoring, but we're always going to treat the what? The patient, and not the monitoring devices. You could go outside right now and be breathing just fine, but it's 20 degrees outside, and put that pulse ox on, and it may not even pick up. Or it may show a low reading because of the cold. I don't think we need to get into all this, do we? I kind of explained the reduced hemoglobin and all that. Oxyhemoglobin. Hemoglobin actually, when it has oxygen bound to it, becomes the chemical oxyhemoglobin. Carbon dioxide, CO oximeter. No, I'm sorry. That's not right. Nah, I don't know what that is. Y'all don't need to worry about it. This peak expiratory flow, this is going to be measurements that they do in the doctor's office. I don't really see you doing a whole lot of peak expiratory flow testing. Oh, here's our arterial blood gas stuff. I knew it was in here. I just, I split up all the PowerPoints. Y'all got a pretty good understanding of this? The base understanding of what we need? Entitled CO2. So as advanced EMTs, we would measure CO2 how? Yeah, colorimetric device. We're going to talk more about, you guys you should be very good with a colorimetric device. What color does it turn? Goes from purple to yellow. Yellow means yes, okay? We're going to talk more about waveform and then digital waveform entitled CO2 detector devices, or capnography, okay? We're going to talk about how to read those waves and all that, but the most important thing is what you already know, and what we're really going to be looking for is the digital, and the digital is going to give us a number. So when we're measuring CO2 that's being expired out, what number do you think we're looking for? 35 or 45. This is just an example of a digital one, and it will go on the end. Now, in the hospital, whenever we intubate, they actually have a machine that looks similar to one of the older pulse ox machines that are bigger. and it's attached to a little thing that goes on the end of an ET tube, and they will actually get measurements, and they are required to get CO2 measurements. And then in the ICU, we are required to, for the first 6 hours, measure CO2, entitled CO2, on an intubated patient. This is a very reliable tool. This is going to be one of your most reliable tools for making sure that you are intubating correctly. Okay? The thing about intubation, and we're almost done, we're going to take a good little break. The thing about intubation is that, I don't know, has anybody been in EMS for longer than 3 or 4 years? You haven't even been in big boy underwear for longer than 3 years. You know, I could have took the highway out, and I just didn't. I took the low road. The thing about intubations is that even back when I first got out of school, which is getting farther and farther away than it used to be. I'm no like 25-year veteran by no means, but I guess I'm working on my 9th year now. Innovation has been on the chopping block for a while, all right? Because if you don't intubate correctly, you're pretty much going to kill the patient. All right? If you intubate in somebody's stomach and you oxygenate their stomach, they ain't getting air into their lungs, you killed that patient. All right? I mean, the disease might have been what killed them, but you're not making things better for them. Let's put it that way. All right? And the thing about it is that you could be held liable, because that could fall under neglect for not doing what? Right. What was that called? And I'm really asking because I can't remember. What is it called as far as neglect goes? Where you are expected to, the standard of care. You're expected to operate your equipment and to act as any other reasonably of sound mind, same level trained paramedic, right? And so, if you intubate in somebody's stomach, you didn't do what you were supposed to do, all right? Whether it slipped out or whatever, you weren't checking right. Nonetheless, these CO2 is going to help with that, because if we're not properly oxygenating a patient, what's not going to show up? CO2, or it's going to be very low levels of CO2. Waveform capnography, we're going to show you on the monitor. And what I'll probably do is actually combine these two classes, and when we get the monitor out for cardiac, I'll show you the waveform capnography then. Waveform capnography, this is actually what you will see on the monitor. Anybody work at a ALS service where they use this now? I know Lynette does. The ETS does? Yeah, they do now. This is what you're expected to see, this wave right here. You've got a couple of phases of waves. I'm not going to go real deep into explaining them right now. Just know that phase A and B, A through B, is your initial stage. B and C is where you're breathing in. C and D is where you're is the plateau phase. All right, so you're not breathing in no more. It's where the air is getting utilized. And then D and E is in inspiratory downstroke. So this is what a normal waveform would look like. Breathing has normal waveforms, just like cardiac monitoring has normal waveforms, and this is what we'd be looking like. Colorimetric device, I don't think we need to really look at this a whole lot, do we? Capnography, it can indicate effectiveness of chest compressions. All right, so it's going to help us know the adequacy of CPR. Also help detect the return of spontaneous circulation as well. All right. Are there any questions about any of that stuff? I don't really feel like today's stuff was near as deep as the stuff that we went through last week.